Have you heard about total endovenous laser? No? Well, it's a technique in which every single hemodynamic abnormality in the lower leg is cannulated and burnt with a laser fiber. It might sound crazy, but there are enthusiasts who claim to get great results and fast. Today, I'm super excited to be talking to one of the leading advocates for total endovenous laser. His name is Piotr Marciniuk from Poland. I had the pleasure of talking to him about total endovenous laser. I'm a skeptic, so I wanted to know more. Let's find out what Piotr has to say. So, I'm very excited to interview you today, Piotr, because I've been on LinkedIn and I've come across you because you've posted quite a bit about this new technique, new to me, because I'm not familiar with this concept of total endovenous laser treatment. And I'm not sure how popular it is, Piotr. Tell me, what was your motivation to go completely into total endovenous laser? Perhaps you'll tell us a little bit about your background, your interest in phlebology, how you developed your interest, what treatment options you've used so far, and why you've moved, seems to me, into the concept of total endovenous laser. What is the concept behind it? What is it addressing? What is the problem that it solves, do you think, Piotr?
Yeah. First of all, thank you for inviting me, for being here with you. It's really an honor. Well, basically, I'm I'm a young vascular surgeon. Yeah. I've been in phlebology since the beginning of my, let's say, career. And I started and I tried different methods, like everything, like from phlebectomies to glue for perforators, for through foam, of course, and everything. But actually, I was never perfectly happy with the results and the let's say how rapid you can have the results. Like you had to have a couple of visits scheduled for a patient to get the result. And I, in my office, actually in our clinics, we run two clinics in Poland right now. There are a lot of patients coming from abroad, and they want their varicose vein, you know. Cut off or get rid of them as fast as they can, and they don't want to come for another visit. Of course, they have to. We always tell them that, like that's a chronic disease and this requires follow-up, right? But to get the result as fast as possible and to get the most favorable aesthetic result, I think this should be done, of course, in my opinion, it should be done with laser because it's nothing limits you. And it's such a universal method that can be used in basically any varicose pattern, of course, except the pelvic leak points, right? But basically, that's very universal, and that's the most important part of it, I think, for the total EVLT.
So, am I right in thinking then that your practice is mainly consists of people coming from abroad?
Well, that's not mainly, I think. It's in our calculations is 30%, but of course there are patients that's still living in a country and wanting their varicose vein being treated quickly, right? So like most of the patients actually, in my experience, they just want a surgery or any procedure done and like forget about the thing, right? They basically, as I really liked one of your videos when Dr. Alexandru Frulini compared like different methods to driving a car, right? But I think it could be modified a little bit, that metaphor. Like you the patient is not a driver. I think we are the driver of the car, and actually car we drive is the thing we choose, the one that we feel the best end, right? And then the patient is a pedestrian or somebody who wants to take a taxi somewhere. And sometimes the patient wants to be very comfortable getting somewhere. It doesn't matter how fast he gets there, but sometimes the patient wants to get there really fast, right? And that
Mm.
thing, I think, is mostly the issue here. Like most patients, different patients with different needs. Of course, well, basically we are doctors, right? So we have to perform and offer the best treatment. But I think we've reached this point where offering the patient a treatment has to be somehow tailored not only to the whole varicose pattern or disease, but also to the patient's needs, right? So it's basically, well, especially in the private offices, I think, in private vein care, that's kind of different. We have reached this point, I think.
Okay. So I'm glad you liked that video with Alessandro Frulini because he's been a phlebologist for 40 years. He's been through all the treatment options. Like you, he started with surgery. Well, you probably didn't start with surgical stripping, did you, Piotr?
Well, it is the surgical stripping too. Yeah. Well, actually, that's the only reimbursed treatment in Poland, actually. So
Okay.
that's a
So
problem, I
you're
think, in Poland.
okay. So you're in the private sector
Yeah,
exclusively, are you, Piotr?
yeah. Right now, I'm
And
only in the private.
And your practice is only phlebology, is that right?
Yes,
Yes, okay. And 30% of your practice is overseas patients who want to come and they want as few visits as possible and they don't want to see you again.
there's a lot of them. Yeah,
And is that the same characteristics of your patients in Poland as well? Do they want speed?
I think 50% of them want to get the surgery done and forget about this. Well, if I were a patient, I would want the same actually. Like, of course, understanding the whole pathophysiology, biological effects, and and the whole disease. Of course, it's important to, right?
Yes.
But basically, well, you want most of the things in life quite to get it fast, right? And that's it.
Okay. Well, and you use the term best a lot, Piotr, in your discussion. It seems like it's speed and it's best. And that is the motivation for endovenous laser, using it totally for every aspect of the vein pathology. Is that correct? Am I characterizing your philosophy correctly, do you think?
I think in my experience and in my hands and the colleagues, the doctors that we work with who we've taught this method, I think that's the best. Of course, we probably had the experience only in foam or only in phlebectomies, right? So I think we could achieve good results, right? But if you're using different methods, I think you're not gonna get, master in this field, right? But and comparing to many phlebectomies to foam, in our experience, laser ablation gives very good aesthetic results, and it's completely safe if you are using it correctly, and the aesthetic results are better, right? So I think that's in our experience, it's better if we perform any other procedure, right, for tributaries.
Okay, right. Well, Piotr, I would like to thank you very much for taking the trouble to send me a video of your total endovenous laser treatment and how you perform it and how you conduct it. And you very kindly given us a video voiceover as well in the English language for me to study. I'm going to show that at this point in our discussion. And then we're going to come back and I'll ask you some questions, or perhaps you can make some comments about it. And then we can perhaps have a discussion where I can challenge you on some of the statements that you've made. How do you feel about that, Piotr?
Yeah, perfect. We can try that.
Okay. All right. And is there anything you don't want to talk about?
No, I'm not open to anything.
Open to anything. So I'm going to show the video and then we'll come back and we'll take it further.
Hello, my name is Piotr Marciniuk, vascular surgeon, phlebologist, and the introducer of Clinic Total EVLT protocol. Welcome to this case presentation demonstrating the step-by-step technique of Total EVLT. This patient presents with symptomatic chronic venous disease following prior sclerotherapy. The mapping reveals post-sclerotherapy recurrent varicose veins with a residual-grade saphenous vein stump, an incompetent anterior accessory saphenous vein, and an interrupted GSV trunk connected by the pava of the thigh. Varicose veins are located in the thigh, medial calf, and knee. A detailed ultrasound examination confirms reflux from the SFJ down through the interrupted GSV trunk and into the pava of the thigh. The reflux is further transmitted down to the posterior calf, eventually feeding into the distal SSV. Here we observe the tributary pattern connecting the GSV to the knee region. The incompetent anterior accessory saphenous vein is associated with minor varicose veins visible on the thigh. Setup preparation includes a 9040 nanometer laser, a 400 micron fiber, 16 G catheters, and local anesthetic. The first access is obtained at the GSV stump. Carefully identify the catheter placement site, and then we introduce the catheter into the target vein. The laser fiber is positioned precisely right at the SFJ to ensure optimal treatment. Here we see the main access points at the GSV stump and the accessory vein. Catheters are placed in all of the tributaries, ensuring access to all incompetent vein segments. Ultrasound guidance is used to navigate and place the catheters precisely. By moving the probe, we locate the target vein and then advance the catheter with precision. This video shows the densely packed catheters, each positioned to maximize treatment effectiveness while minimizing trauma. This is the key highlight of Total EVLT. We scan the target tributary in plane before access, checking its complexity. As the catheter advances through these challenging segments, careful needle maneuvers ensure continuous intraluminal placement. This technique prevents unnecessary perforations and enhances safety. This video provides another example of advancing the catheter in tortuous tributaries. Maintaining intraluminal placement requires controlled, steady hand movements with real-time ultrasound confirmation. In some cases, extreme tortuosity prevents straightforward intraluminal advancement. Here we apply the skewer technique, puncturing through varicose loops while maintaining as much intraluminal access as possible. With all catheters in place, 25 in total, we now have complete access to all varicose segments. The procedure begins with the flush ligation of the GSV at the saphenofemoral junction, ensuring no residual stump remains. Tumescent anesthesia is administered around the tributaries using ultrasound guidance. Regular tumescent needle and pump is used. Tributary ablation is performed using the ultrasound-guided laser ablation technique. The lead is adjusted based on pullback speed and power settings. Energy delivery depends on vein wall thickness, the degree of tortuosity, and proximity to the skin and other vital structures. Proper tumescence is always essential to enhance efficacy and minimize the risk of thermal injury. Here we demonstrate another example of tumescence administration and ablation for tributaries, following the same principles of controlled pullback and precise energy delivery. Tumescence placement around the knee region and any other superficial areas require extra precision due to the limited subcutaneous tissue. Proper needle positioning above and below the vein ensures an optimal protective buffer. Ablation of very superficial tributaries demands a more accelerated pullback while continuously monitoring patient feedback. Adjusting energy delivery in real time prevents complications. The procedure is now complete. No incisions were necessary, only small puncture sites. The varicose veins have visibly disappeared. Key highlights. The 45-minute procedure was performed under local anesthesia with a patient-reported pain score of 2 out of 10. No incision, no foam, just pure laser. Thank you for watching. If you are interested in learning more about Total EVLT, feel free to contact me by email or LinkedIn.
I have to say that having looked at your video, it's clear that you are very skilled. You're very skilled at cannulating quite difficult veins. You're very skilled at placing laser fibers and applying the tumescence. And you say in your video that you do it in about 45 minutes.
Yeah,
Now,
only the procedure takes about 45 minutes, but in total it's like around 1 hour with a patient walking in and out.
well, that I think that's pretty exceptional because I think, and I know you're a lot younger than me and you're a lot quicker probably, but I don't know how many catheters or cannulas you place for an average procedure. How many would you say you place, Piotr?
Yeah, that case and the video is 25. It's rather a lot. In most complex cases like this one, like a regular case with the GSV incompetence and varicose veins on the medial calf, that's usually from 5 to 10. That's a usual number. Yeah.
So that video that you showed and some of the before and after photographs that we also showed, they have 25, 30 cannulas placed. Is that right?
Yeah, the maximum number I've placed it was 80.
And how long would that take you, Piotr?
That took 2.5 hours.
So the characterization of a procedure taking 45 minutes, you would say, is between 3 and 10 cannulas. Is that right?
For you mean for like a regular case?
For a 45-minute procedure, how many cannulas do you think you would place in a
45
45-minute?
for a 45-minute procedure, that would be around 15, 20. Like this, yeah.
Still pretty good going. Placing 20 cannulas accurately, then applying tumescence, then delivering the heat energy and the drawback, all in 45 minutes. That's very quick.
Well, basically, the regular EVLT is around 15 minutes. So for the GSV or maybe 20, right? But when you switch to the second stage, the tributaries treatment with laser, it's if you've done that quite a lot of those procedures, it goes very smooth, right? Because if the mapping, because we have to, let's say, divide the procedure of the total EVLT in the key parts. So the basically the key part is the mapping, right? So you have to be very familiar with the case, with its how the varicose veins are placed on the leg, right? So the whole pattern, and then after there are cases, of course, when the varicose veins are tortuous, but they're not that tortuous. And these cases, you can easily place the catheter distally and cannulate the whole varicose vein with laser fiber just from the only one puncture, right? So you have to be able to judge those places, of course, not to over treat, not to over puncture the patient, right? Um, yeah, that's one of the key points I think in total EVLT. And of course, another one is basically the safety stuff, right? So the proper tumescence, right, and proper energy delivery. That's very important.
Okay. I'm still very impressed because as a technical exercise, it's clear that it's quite difficult for the average person, I would say, the average phlebotomist. Um, I think it demonstrates a large amount of skill on your part, and I think that's That's very impressive.
I have experience of around 2,500 cases, 2,500 cases of total EVLT, of pure total EVLT. Of course, well, I've tried everything. Let's say, well, maybe
Okay.
not everything, but to make it the best in outcome and aesthetic result. I've tried different fibers. I've tried different laser lengths. I've tried different approaches to start with, to end with, right? So basically, that's a result of trying, right, to find something.
Okay. I'm skeptical about total EVLT, so I would need convincing, Piotr. So tell
Mhm.
me, you've done 2000, over 2000. Where have you published your results?
It's not published yet, but we are working on that. We have a speak in Vein in Venice.
Yes.
Look up Columbus Vein in Venice, which I think is going to be a very nice conference, and hopefully on the European Venous Forum this year in Krakow.
So on what basis do you assert that it is superior to foam sclerotherapy? What is the basis? Where are the results that you would convince me as a skeptic about total
Hmm.
EVLT?
Well, first of all, I don't want to like sound as I don't use foam. Of course, I use foam. Especially at the beginning of starting total EVLT, you are not that skilled and that used to cannulating all the veins, right? And in this case, like additional adjacent foam sclerotherapy is perfect just to like close everything that you couldn't manage to puncture. But after some time, you're able to cannulate every varicose vein, right? With let's say it's rather more plausible to puncture veins that are more than 3 millimeters. But of course, you can even puncture smaller ones, even reticular veins, with those 16G catheters. Basically, that's something that when you why it's better than foam, right? I think that we shouldn't say that it's something is better. First of all, I think that it's rather like. Those methods are synergic, right? So, of course, for rapid effect after just one stage procedure, it's perfect to use laser. But of course, for any additional, like anything, any residual varicose veins, right? Or very small recurrence. So for as your concept that I really like, so the total vein curve, it's perfect to use foam.
Why are you striving for total EVLT? Because it's the best, because it's the fastest. I put it to you again, where is the evidence that it is the best? Provided you have the technical skills, and you certainly have, and you're able to cannulate refluxing veins and perforating veins and tributaries, where is the evidence that that approach is better than total foam sclerotherapy?
There's no public evidence, right? So that's still issue. But in my experience, it's better, of course, than sclerotherapy because it gives you the possibility to perform the procedure in one stage. And I couldn't ever do that with sclerotherapy or any other method. Or of course, performing extensive phlebectomies can give you that kind of effect, but it's more traumatic for the patient and more, well, the aesthetic results are worse after phlebectomies, I think.
Well, I think other than the fact that you say you can do it in one go, I don't think I would agree with any of the other reasons. I don't think that you have shown that the aesthetic results are better, and you haven't shown that the outcomes are better. What you say is that you're able to treat everything in one go. And some people would say that if you were to look at these people and say 5 years later, there would be no difference. In fact, you may not show that your procedure is better, and that the procedure that you're doing is achieving speed in the sense that you're able to do it in one session, but you haven't proven or you haven't got any evidence that it's any better than foam sclerotherapy.
Well, considering like, for example, the aesthetic results. I think, well, in my hands, it gives better results because I was always very skeptical about those stains, hyperpigmentation, about sclerotherapy. And you had to perform all those thrombectomies all the time, and that took time. After total EVLT, there can be some hyperpigmentation, but usually that resolves spontaneously in 1-2 months. And if it's persistent, then of course you have to puncture it, but it happens much less common than after sclerotherapy.
Yeah, I understand you're enthusiastic about EVL, total EVL, and I can
I
see
really
that.
I really like it.
Tell me, are you a graduate of the College of Phlebology?
Mark Whiteley's. I am a member,
Yes.
yeah, but I didn't do the fellowship.
Are you persuaded by the Whiteley protocol?
Kind of, yes, let's say. Yes, I
The reason I ask is that it sounds, from what you're saying, it sounds as if you're an enthusiast for treating all the hemodynamic abnormalities, the truncal, the perforators, the tributaries, using endothermal ablation. And it sounds reminiscent of my discussion with Professor Whiteley. And I just wondered if you were aligned with his thinking at the Whiteley protocol.
in this particular issue, I am. I think I'm very radical with treating any hemodynamic issue in the patient, treating large re-entry perforators, all the potential places where the recurrence can occur, and of course treating the pelvic leak points. But I'm in general, like in case of those this pelvic venous disorders. I think that it is indicated to perform embolization and another like a top down approach in patients with just with symptoms, I think. But in patients without symptoms or only with vulvar varicosities or something like that, that it's better to well, it's better. I think my philosophy is just to do the bottom up treatment in those patients for the leak points.
With laser.
Uh, I would love to do that with laser. I've never tried that. I don't have the guts to do that yet.
What do you
But
use then? You use foam sclerotherapy?
I use foam, yeah.
Okay. So again, I ask you that approach, treating aggressively all the leak points, all the perforators, all the tributaries. Do you have any evidence that that gives better long-term outcomes?
With the protocol that we use, that is,
Yes.
let's say, complete right now. Of course, we
Yes.
started trying different stuff. We have like a 2 year follow-up, and that gives very good results in terms of recurrence. It's really like I've never seen a neovascularizations after total EVLT. The only thing that I sometimes see is, but it's probably because of the low energy delivery too low energy delivery is some spontaneous recanalizations of popliteal perforator veins. But basically, the other veins that are, if they are treated, and that's my approach that it's treated with a flush ligation of the GSV gives very good results, especially in the groin, in the junctions, right, or in the popliteal fossa.
Well, I think it's very interesting because obviously there's a difference in philosophy here, isn't there? Because your philosophy, if I'm correct and I'm not mischaracterizing it, is that you should treat all the hemodynamic abnormalities, all the tributaries, all the perforators aggressively with endothermal ablation as a first instance. And you call that approach the total EVL. It sounds very much like the Whiteley protocol. Do you see any differences between your approach of total EVL versus the Whiteley protocol?
Well, I'm not sure. I don't know the exact like approach that is in the Whiteley protocol. If they treated everything one stage or well, basically, but the concept of treating everything that is responsible for the varicose veins, well, that's similar then. That's my philosophy too.
And you're not persuaded by trials that show no difference between endovenous laser, endothermal, foam. Many experts, much wiser than me and perhaps with more experience than you, would say there is no difference between any of the treatment options it's a chronic disease. You're going to have to treat them again. They're going to recur.
We'll find out, I think. We'll find out if that's an issue. Of course, that well, basically, what I don't like in phlebology that it's extremely hard to perform quality
Yeah,
to find something. It's like there's so many possibilities, so many patterns, so many no group is homogeneous to compare it with another one. So I don't know if we ever manage to find an answer to that because we have to really uh, really prepare the methodology so extensively that I don't know that would take years or impossible personal resources to perform, right? But I hope so that we can manage to find it. And basically that kind of studies are published anywhere. Like there's a lot of exclusion criteria and all of those kind of stuff that I thought don't know if that's real world populations to that we can actually study and the recommendations, of course, are recommendations, are not orders. They are based on that studies, right? So of course, giving the results, especially in private practice by different centers and showing them and presenting them somewhere, they're somewhere, of course, gives some kind of bias, right? That you tell that of course, your procedure is the best, right? Everything's the best that you do, and you have no recurrences, no DVT, and something like that. But you have to prove it, right? You have to prove it, of course. Well, you always have to have somebody supervising you that if you're not cherry picking or something like in your studies. But I want to show it that our approach gives good results and that they are replicable and they are universal. Actually, anybody can try it to do that, but it requires some time. There is a learning curve, of course, in this. If, we have some experience with that, teaching our colleagues. It requires like, I don't know, 50 procedures to be familiar with the concept and to be, let's say, to work alone or no supervising around 100, I think. That's quite a lot, I think,
mm.
but it is replicable. I think the reason why it's around that many cases is that we use the ultrasound guided laser ablation, right? So that requires experience. You cannot measure this and say, of course, the pullback speed is a specified stick number, and the lead based on the vein diameter is like something like that, right? It's not that easy, especially, well, every patient is different. Every patient has different depth of subcutaneous tissue, tortuosity of the varicose veins. So basically, that's something you have to learn. And the most important thing, you have to follow up this patient and see how it closes when you remember that I used that much energy in this place and it closed or they didn't close it. There's a lump, there's some duration, there's something that you have to perform the thrombectomy on. So that requires some experience and time that you have to give to that.
How do you manage the recurrences that you get?
If that's a recurrence, like small recurrence or a residual, very small venuloplegia or small varicose veins, I use foam. Of
Mm,
course, that could be performed with another laser procedure, but that's not cost effective, I think,
mm.
because you have to use another laser fiber and
Well, Piotr, it's been very kind of you to give your time, and I've learned a lot. Thank you very much. What I've learned is that you are an enthusiast for the technique. You've obviously spent a lot of time perfecting your technique. You believe in it very strongly, and you, in your own opinion, you get the best results that you can using that technique. I would find it difficult to adopt that technique, I have to say, but I'm very impressed by the work you're doing, and thank you for sharing it. Thank you for taking the time to take the video. Is there anything else you think you want to say to me to persuade an old phlebologist like me to take on this new technique?
well, that's well, I know that I'm young, right? But well, I have like almost 10 years experience in phlebology. So I'm not very, very young, I think. I've worked in this field for
How
quite a long
old
time.
are you, Piotr?
I'm I, yeah, I'm almost 35, 35.
Yes. Okay.
All right.
And you're at your peak. You're at your peak of technical skill.
Yeah, that's well, yeah, of
And
course,
you're,
like going just in phlebology was a hard decision for me.
yeah,
Of course, like I was really fond of all those arterial procedures that we performed in the hospital, and I really liked it. And I found I well and enjoyed that, right? Um, but when you do everything, you're not never good at everything, right? But you have to decide what you are into, and that was my one of my reasons to do that. And the other one was, of course, the quality time and work-life balance, right?
yeah,
So
yeah.
yeah, and I
That's
think
very important.
deciding young as you actually have to have the life ahead of you, hopefully that is essential to do what you really want to and not work over hours and like that's it.
One last thing. What if you find out in 10 years' time that the total EVL was not the right philosophy? What if you
Uh,
find in 10 years' time that it's just the same after 5 years, 5 years after your treatment and 5 years after foam sclerotherapy? There's no difference. People are equally happy. The
well,
results are the same.
I
What
would be
would you do?
happy that I would be happy that you can achieve the result with different techniques. Right? That's the first thing. But well, what can happen in 10 years' time? Of course, we can have another miraculous procedure that can, like the of course, well, that's in the early steps. What I want from my personal point of view, that I don't want to be so stuck to one kind of thinking. I hope that we will be open for any other thing that comes up and is possible to perform, and I want to learn it. And I have that kind of I don't know. That's if that is not inappropriate, but the phlebology. Sometimes the phlebologists they can be named phlebosaurs.
Lebersaurs.
Phlebosaur, because sometimes people they don't want to change anything. They are stuck to the methods that they've performed for the whole life. And I think, well, I encountered a lot of actions or a lot of negative comments in Total EVLT, of course, right? Because well, if somebody is used to some other procedure, they don't want to try anything else, and they are, of course, that requires time. That requires time to invest in. Like requires some a lot of work. Well, I'm always open to try new techniques. Well, I started using Varicose, and I'm perfectly happy with this. It's a perfect device to create foam, and that's these kind of, well, maybe if I started using Varixia a couple of years ago, I would be foam enthusiast as you, because, well, the results are very good. Well,
Mm.
it's a matter of point in time that you are in,
Yes,
and
yes.
that
Yeah.
yeah.
Yeah, you're open to new ideas. I think I admire your skill. I admire your enthusiasm. I appreciate the fact that you're trying to get the best results for your patients. And thank you for sharing your technique, Piotr. I'm very pleased. I will publish this podcast and we'll invite some comments. I hope you don't get negative comments
Well,
because
I'm alright with
that's not
this.
that's not the point of talking to you. I don't The reason I'm talking to you today is because I don't know anything about it. I don't know enough about it. And I wanted to speak to somebody who actually does it. And what I've learned is that the data isn't there. You've made some assumptions that endothermal ablation is better than other treatments, such as foam sclerotherapy or phlebectomy, and you're taking that to its logical conclusion and you're applying endothermal ablation to all the hemodynamic abnormalities and the tributaries with the skill and cannulation and the techniques of different laser fiber diameters and puncture techniques, and you are closing the veins. You don't have the data, and we don't know that there will be a difference in outcome. It seems to me that you're motivated by trying to do the best for your patients in as few visits as possible. And I have no argument with that. I'm not going to argue any further because we're all entrenched in our positions. I think we've agreed that there is no evidence yet, but hopefully there may be, and we will see. And I'm trying not to be an old phlebosaur.
No.
Piotr, thank you very much. I'm going to wrap it up there. And thank you very much for taking part in this podcast. Thank you for sharing your technique, Total EVL. And perhaps we'll meet at a conference and we can shake hands. Thank you, Piotr. So there you are. That's the technique of total endovenous laser. I have to tell you, I'm still skeptical. I don't think that Piotr has made the case sufficiently to convince me that total endovenous laser is superior to ultrasound-guided foam sclerotherapy. Sure, in his hands, it works. But can it be rolled out? Can it be scaled? I don't think it can, and I don't think it can address the public health issue of venous care in the United Kingdom. We may never know whether one treatment is better than the other. All treatments seem to work equally well with regard to patient-reported outcomes. And let's face it, that's what really matters. Well, thank you for watching. Thank you for staying to the end. Be sure to leave a comment below. I read all of them and I'll try and get back to you as soon as I can. If you enjoyed this and you found it useful, please give it a like and consider subscribing. That way you won't miss my next video.